their background. So Amy, can you get us started, please?
Yes, good morning. Thank you everyone for joining us. My name is Amy Meek. I've been a nurse in this community for about 24 and a half years. The last 11 of those I've worked in public health. Right now I manage our Monroe County Public Health Clinic, which is the nursing division of our health department, but it's through IU Health. And I manage Nurse Family Partnership, which is why I'm here today. So Nurse Family Partnership is a home visiting program for first-time low-income moms, and it pairs a registered nurse with that parent from early prenatal care all the way till that baby turns 2 years of age. And that program started in this area in 2018. It's not a new program. It's been around for over 40 years, but it's been new to our area since 2018. So I'm excited to tell you more about it.
Hi, I am Lori Terrell. I'm the clinical manager for a program at IU Health Community Health called Family Vitality. I work similar products like Amy, except for I'm not identified as first-time low-income moms. I am actually helping to assist with care navigation for moms who experience present and or past substance use. So helping guide them into care, meeting them where they are and getting them connected to services during pregnancy, as well as following them out past pregnancy into the postpartum period and helping to connect their babies to needed care for 2 years of age, much in the same fashion that Nurse Family Partnership does in connecting them with pediatric care. Prior to that, I spent 30 years in the primary care pediatric setting at Riley Physicians. So I have been a longstanding member of the community, and this program started in 2019, so it is relatively new. We learn new things every day, but we're also working on some program development to kind of augment the care to moms specifically identified with substance needs in the community.
Thank you, Amy and Lori. I'm excited to get to a whole stash of questions I have for you guys to learn about your work. For those of us who can get our minds into the right space of thinking about early development and this very early stage of life, I've got a little video to share.
Our earliest experiences begin in the womb, form the template of who we believe we are, about how we see other people and our place in the world.
Well, we know how important that early time is. Early development is critical for the brain. We know that the early brain structures are formed in those early life, in that time period. And we know that some of the brain structures that are formed at this time period, the structure matters for the whole life. Current research suggests that the parts of the amygdala, the prefrontal cortex, the hippocampus, that development is deeply associated with the quality of care received in infancy. So the quality of care that infants receive influences the structures and the circuitry of how the brain is formed. So that's why we know that early development is so important. And we know that this period of life is the sensitive period. It's that important time for the parental shaping of those structures. And so those of you who have been with our summit before and have joined us for other summits in the past know that we often talk about safe, stable, nurturing relationships and environments. Oops, sorry. The CDC, oh, I'm all over the place. Sorry about that. I just want to give you a glimpse of the SSNREs. Safe, stable, nurturing relationships and environments. That comes from the Essentials for Childhood framework from the CDC. And that's why I asked Amy and Lori to be here today, because I think that the work that they do really focuses on helping families provide safe, stable, nurturing relationships and environments for their infants and their little ones so that they can help form that early development that is so important. And so that's the background of what I'm thinking about today. Earlier, you heard a few of our speakers talk about what surrounds us shapes us. And boy, how much more is that applicable to babies? What surrounds them shapes them. And Lori and Amy help with that surrounding piece. And so I have some questions for them. So that's how we're going to run our session today. I have a variety of questions for Amy and Lori. You might have some questions too. You might have your own responses to the questions. Feel free to put those in the chat. And then once we hear some insights from them and kind of get some ideas kind of tossed around a little bit, then we'll open it up to everybody else and we can all share some more of our contributions to this topic. So let's go ahead and get started with kind of a big and general question. And that is, Amy and Lori, from the work that you're doing with families in early development, from prenatal to the first 2 years of life, what are some of the big insights that you guys have gained from your work?
For myself, I mentioned I've been a nurse for 24 plus years and in public health for 11. So I felt like I knew our community really well. I've always worked in this community. I felt like I knew barriers. I understood that when we give discharge instructions and we do patient education, there's always these barriers that we don't know about that relate to why they're not able to follow through with some of those things. But until going into a home, I had no idea what I didn't understand. And so the biggest insight for me is just how important home visiting is as a part of healthcare.
I would say for me, the one thing that I've learned is the need for moms to have a personal connection and feel that it's without judgment and stigma around what we're having conversation about, and to build trust. Unfortunately, a lot of the moms that I work with have had negative impact experience through either healthcare or they've had to be involved in the DCS system, which has felt negative to them in the aspects of how it happened. And so it's really hard for them to feel like they can give honest and vital information and know how to assist them and what their barriers are. I've noticed a lot, for example, when I see a mom who has a social service visit through the hospital, one of the things I see as a very big trend when it talks about any financial concerns. And I don't know about you guys, but when I had my own children, I was bringing another life in. I was going to be off without pay for maternity. There were financial concerns, but almost always these individuals, even if they have no employment, they say no. And I think that just shows a concern or a feeling to be honest about what their concerns or their struggles may be, for fear that that may have negative impact. And so, just building those trusts and trying to help moms understand in advance the role of social services, the role of DCS, the desire to see them succeed and stay unified, but having them help build that level of trust takes some personal experience and some continuation. It's hard to connect with some of the moms. But I agree with Amy, when I get to go visit them in their home, I feel like that's opened up another door. It's allowed a lot more insight and they seem to be a little more sharing, and you get a better idea of just the amount of barriers for their daily services that they have.
Yeah, but the title of our session, I grabbed a phrase that Amy had said when we spoke before about what we didn't see until we were in the home and seeing all the factors that were influencing the baby's development that may not look like they were specific to the baby, but they were specific to the caregiver and to the home and to the environment, and then therefore influence the baby. So that home visitation and getting to know them personally is really a really cool part of what you guys do. And I know that you two focus on some specific targeted populations, low income or substance use. But I know that a lot of the work that you've done for systems change influences not just your own clients, but it influences families in general. Some of the stories I've heard about the work you guys have done with Medicaid and different other agencies that influence populations beyond your own clients. So can you tell us a little bit about any of those systems changes that you've had to work with to try to support new families?
So one of the big advantages to this community is how well connected we are. I know sometimes we feel like we're not well connected, but if you look at another community, we're actually really well connected here. So when we recognize a barrier that our nurse family partnership clients have, we know that it's not just them that has that barrier. There's a lot of people out there that could use a home visiting program or could use some support. If our clients have that barrier, so do other pregnant clients. They have that same barrier. And being connected as an IU health system, being connected as community health, being connected with other partners in the community, it just lets us make those changes that are system-wide changes a lot easier. And I'll let Lori elaborate because she's done a lot of this work. But one of the early things we recognized was we had teen parents who, they're 16, 17 years old and they're home alone with their new baby. They can't even go to the doctor because they don't have transportation. And of course, we have Medicaid, so we can call Medicab, but we can't because they're not an adult and Medicab won't pick them up, even though they're the parent of the child. They can't get their own child to the physician's office. And so Lori stepped in and really led that charge there.
Now we worked to address the issue of transportation, because not only is that the issue of we had with these young individuals who were able to make medical decisions for their infant, but were not able to get their own transportation to and from because Medicab programs require there to be an adult 18 or older riding alongside with them. So we were able to reach out to the FSSA and some contacts that we had as part of those community builds, and work with Rios and kind of get some connection into the right individuals there. And Medicaid has now made some changes to their transportation where they will allow minors to be transported for services so that that's not a barrier for their care. Also coming about is a very big picture that, for most with Medicaid services, their postpartum period ended at 60 days. And that's really quickly after they give birth, knowing that they may have some ongoing health needs. We see an increased risk of postpartum depression. That's not something that's usually resolved by the 60th day postpartum, which means that they fall off of some services. So working again with FSSA and give support to Indiana to move forward and accept a 12-month after postpartum enrollment period. So moms can now stay on. Starting in July, they're able to extend that stay until a full year after birth. So kind of some things that we identify as gaps and barriers. Also working to help identify more needs for mental health services, substance services covered under the Medicaid programs. Transportation still remains to be a huge component. And we have been very good at communicating back concerns. We find in our areas that a lot of times the Medicab cancels. The process is you have to schedule them 48 hours in advance, but they can call you the day before to say they don't have a transportation provider. So transportation still remains to be a huge issue and concern, especially as you look in the rural communities that surround us, where there aren't many options for services there for transportation. But just kind of working through those connections to see how we can build and help support those who need those services.
Thanks for sharing that. It makes me think of something we've talked about in some of our summits before, the social ecological model, where we can do change at the individual level. We can just ask individuals to change what they're doing, just get better transportation, find somebody to take you. But if we move up the model and talk about policy change, a policy change of an age restriction or something like that, that can trickle down and then support lots of people, then we don't have to keep relying on individuals to make different choices. We can create structures that make those choices easier to make. So I'm glad to hear about that. And it makes me think about also some of the work you guys have done around family planning and birth control. And I think that kind of ties into some of the systems changes. So can you talk about that a little bit, please?
Yeah, the system change part is the exciting part sometimes for me too, because you can see a bigger impact. One of the barriers we identified with Nurse Family Partnership right away as well was family planning. So our clients would leave the hospital without any form of birth control. They would have a postpartum appointment at 6 to 8 weeks. Just getting to that appointment alone is a huge challenge. We would help them with that and try to ensure that they get there. But then even when they would get there, a lot of the times there would be a discussion about family planning, but no actual birth control options given or anything. So they have to make another appointment to come back for that. And so you can see where that barrier falls, and it was hard even to get to one appointment, let alone get back to another one. And so, we had some subsequent pregnancies that, weren't really planned and weren't what the client's heart's desire was at the time. And Lori again stepped in to help us with that and talking with the system and getting some things changed.
Yeah, through the system, for my years in pediatrics, we had a hospital multi-system program that we called Ped Teen, Ped Domain, that did a lot of work just on organizing and seeing gaps in structure of care. So under my role of Family Vitality, I worked to see if we could organize a very similar structure for OB. We started out, in all honesty, working as a group between inpatient administration on the mom baby unit, outpatient OB, as well as addiction psychiatry through IU Health, just trying to talk about how we could smoothly initiate moms to Suboxone from other opiates and do that in transition of care during pregnancy and supply those supports. From that, which is much what happened in the PED group, we realized there were other gaps that we kind of needed to talk about. And so we've kind of retitled our group kind of more OB care navigation. And we picked up the topic of how can we avoid some of these gaps where we have moms who know maybe transportation will be an issue. There's also interpersonal violence where reproductive violence is a thing that we see in moms that we serve, where reproductive health is kind of held at their partner's decision. So they may let them come to a postpartum visit to be checked, but maybe won't let them return if they think they're going to have birth control services, long acting, such as IUDs or Nexplanons. So trying to figure out for those moms who may have those situations or may just know up front they're going to struggle to get to return appointments, how can we streamline so that, for one, we have education and opportunity for services to be provided safely on the floor prior to discharge. So if a mom knows she wants Nexplanon, knows that she really is likely not to be able to return to her postpartum, can we go ahead and do a Nexplanon insertion prior to discharge? So looking at what those policies and procedures would be, how does that education roll out? So here locally at IU Health Bloomington, nurses there's a brochure they go over to talk to moms about options for birth control, just so there's some beginning forms of conversation. OB in the area usually starts that conversation at 32 weeks, but typically people are kind of feeling that big and kind of pregnant and not really thinking yet of what they're going to do after delivery. So it's a formal way for that conversation to be initiated. If somebody wants something on the floor, then the nurse can help associate that conversation and get that going for the providers to be aware. We are also taking some additional steps to streamline their postpartum appointments. So any mom who delivers, the unit coordinators send information out presently to the IU Health providers. We don't unfortunately have a good process set in for Dr. Laban, who's not part of the IU Health, because the messaging system is a little bit different for that. But then they notify so the office can give mom a call to get scheduled as soon as possible for her postpartum. And at that, working to organize, if mom has a plan that she knows she wants to have for her birth control options, getting that scheduled as a one appointment time versus previous stay where they'd be scheduled 6 to 8 weeks, need to come back in another 4 to 6 weeks to get those services. So we've been kind of working on what happens in structure. How do we identify those gaps? How can we make it smooth and accessible for those who have that interest and desire?
That's a great example. You talked a lot there about the partnerships that you needed to develop with other organizations to have system change and to think about what made sense for the overall care. Can you tell us a little bit also about partnership in general as it relates to the families you serve and kind of what that means to you guys to be in partnership with the families?
Okay.
Sorry, I was waiting for Amy to go. It's all in the title.
Okay, I'll go first then, sorry. Yeah, so nurse family partnership, that's in our name even, right? So that's the whole program, really. It's relationship-based care. And that's something that as nurses, we love so much. You go to nursing school and you learn about this sort of thing, and then you get in the real world and it's so busy and overwhelming. You don't get to practice sometimes what you really learn to do. So our nurses really love their job because they get to build a relationship with the client, not just take care of them. And we have some kind of core values around nurse family partnership that we follow. And one is only a small change is needed. Follow the client's heart's desire. Focus on strengths. Focus on solutions. And the client is the expert in their own life. And just being able to embrace those concepts in coming alongside the client has been a game changer. We don't tell the client what to do. We don't set goals for them. We come along, we partner with them, and they set their goals, and we help them realize what kind of resources they might need to meet those goals. But It's not a discharge order where we tell you do this, 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 and this, and it'll be okay. Instead, it's totally a partnership from day one.
Yeah, and I would have to mirror that. Amy has a great process in following the national program for nurse family partnership. Mine is a homegrown kind of developed program working with Family Vitality. So I don't have some of those similar processes already in, but I agree with Amy so much in coming from a healthcare setting, we're used to giving people instructions and these are the things to do. We want you to have these 5 things done. We want you to take these meds. You need to be here on time. But really the role that I play now is very much being their partner. Why I would love to see everybody in total abstinence from every substance. I have daily conversations with moms about what are your plans? What is it you want to see happen? Because they have to be in charge of their own and they have to see people supporting. And for me, it's more any type of reduction is harm reduction. So if they're using a substance less, if they're practicing safer mechanisms, if they're going to the needle syringe exchange to have clean needles versus before using dirty needles, that's a step toward harm reduction. So I think when you take off the hat of, gosh, this is really not where I want you to be, and take the hat of, how can I help you get where you want to be? There's more success and more opportunity. And they do feel a better trust and bond, and they let you in. They share things that you would have had no idea, which greatly impacts maybe what their delivery looks like, how they grew up, what kind of repeated cycles you may have a concern for as they work on child raising for their child themselves. So how can we avoid some of these repeat patterns? And part of that is letting them be a partner in their care and not feeling like they get care dictated.
Each of you have spoken about building a relationship with your clients, and I'm guessing you see the importance of the relationships they have in their lives, obviously with you, but then with the other people in their lives. Can you talk a little bit about the importance of relationships in forming healthy relationships and what influences early development?
Yeah, so one of the theories that nurse family partnership follows is that attachment theory. So knowing that an infant needs that solid attachment with at least one primary caregiver. And we notice with our clients that's difficult sometimes because they never had that. They never had that chance to have a positive attachment with anyone. And we talk a lot about adverse childhood experiences and how that has affected their life. And hopefully they had a chance to build some resiliency as a child, had a chance to connect with someone that helped build them up. But if they didn't, then that's what we work on too with the client, is helping them build resiliency now so that they can be that for their child. And those ACE screenings is something that is actually part of the OB practice as well. So they do that screening with every pregnant person that comes through the offices. If someone has an ACE score of 3 or higher, then they're automatically referred to an appropriate program. So Nurse Family Partnership is one of those. Family Vitality is one of those. There's a lot of on that list: Healthy Families and Centerstone, Early Head Start, lots of other great programs in the community. So depending on that client's level of need, they get some kind of referral there. But building resiliency and that attachment is a big key for Nurse Family Partnership.
Yeah, and I would say, I mirror Amy in that. What I see a lot is generational of lack of those supports that they've had, or those positive role modeling impacts. A lot of my moms are 2nd and 3rd generation substance. So some of my moms talk about their experience of being originally placed at some point in life with their grandparent, but then their grandparent also having substance being removed, and what that's like to kind of be bounced around and not have a sense of stability, and how that impacts their relationships and their thoughts and how they make decisions. So I think those protective factors we see are so important, but unfortunately, a lot of individuals miss out on those protectant factors. And so how as a community, when we have families who struggle with internal protectant factors, what community supports are there to make those? And so how do we connect? I'd make a lot of referrals inside of my program to other services. So Amy mentioned Early Head Start, Healthy Families. I refer to NFP when they qualify for their group. And all of that to me, as I talk to the parents, as I'm working to make these referrals, is about helping them find positive supports, positive peers and connections to kind of help revert a cycle so they have those sense of supports.
Yeah, I have a sentence here I'm actually going to read because I think it's so important. I don't want to mess it up. Infant attachment to the caregiver occurs regardless of the quality of care received. And I think you guys have talked about seeing that. And I've heard lots of families who work with children who've been in foster care will say that too. That attachment is so important to the infant that regardless of the quality of the care they're receiving, that attachment to their primary caregiver, whoever they identify that is so important. And earlier I mentioned how that attachment forms the brain structures that set the foundation for their later growth and then strengthen their ability to have emotional responses later in life. So I want to stay on that topic for just a minute, if you don't mind. You talked about the importance of relationships and how you refer to other services. Do you have any thoughts on what our community or where our community could grow in strengthening healthy relationships so that we can form those attachments more solidly and for children to be able to develop with that attachment?
I have some thoughts on that one. I think back to my years in Peds where we used to have a program, I think it was called Parent Aid, where we could make referrals to parents who needed help connection for those positive supports, helping with difficult struggles that they may be experiencing through behavior. So they build those peer groups that are positive and peer grouping. And through funding over the years, some of those supportive programs have went away. I was really glad to hear in the opening remarks about the basement level of the library, because what a great way to get kids to have that opportunity to have that socialization and build friends. But we don't really have that for a step up for adults. So a way for them to engage with other adults in programmings, to have questions and just build those friends and supports.
And I'll add something that we see in our clients. We could have two similar clients who've gone through similar experiences later in life. And if you look back, you can almost guarantee one that has more resilience had early childhood attachment and early childhood positive experiences. Maybe later on things went the wrong way, but that early childhood attachment is so critical to the rest of their life and how they deal with other traumatic events. I think the one universal is our schools, and every kid goes to school, so it's hard to catch every kid at the office or even our WIC office. It's a very trusted place, and a lot of clients will come in here and trust the WIC staff with information. But for kids, everyone goes to school in some way. And if there can just be some more, mental health services in our schools, peer groups in our schools, someplace there where they can make positive attachments as well. I think most of us have that teacher that we had or a coach that we had or someone in our life that you knew they really believed in you. And so embedding some more just help in the schools, I think is a big thing.
Also looking at the community in terms of what there is for you to do in a safe, congregated manner. Years ago, there used to be places that kids could hang, and there were adults that were kind of around in the area, and I'm sure there was mischief that happened, but there was also something to do. So if you're not active and engaged into a sport or, into an extracurricular at school, what is it that you can do that would be in a community that is safe and has some positive aspects?
I am a school teacher, and often we are focusing on how to help kids feel safe, engaged, connected, and supported. And hopefully that happens at school. And if not, hopefully we're catching them in other places like the Boys and Girls Club and other community places that we'll be talking about at other places or other sessions in the summit too. But that brings me to kind of a general question similar to what we've talked about. And that's, you're doing so much for your clients, and so many of the systems changes that we talked about, and I'm sure there are many more, don't just benefit your clients, but they benefit parents in general. They benefit new families all around. But I want to acknowledge you guys can't do everything. So I'm wondering if, as you've gone through your work, if you've noticed places in the community or places where collaboration could be stronger, or where we could focus on some collective impact in a different way, where you're seeing like, oh, if this group just got together with that group, or you know what, we're really missing this particular piece, but I can't work on it right now, but I hope somebody else can. So if you're thinking about outside of your work, have you guys identified anywhere where you think the community has room to grow?
So for something we've recognized in Nurse Family Partnership that I think could be embedded in the community a lot more is just mental health care in general, of course. Our community has a lot more mental health options than a lot of communities, but there's just never enough. We were able to hire a licensed clinical social worker this past year to kind of bridge a gap with our clients. So if a parent is experiencing depression, anxiety, even just needs to work through some trauma, sometimes helping them engage in mental health care, there's a lot of barriers to that. There's a lot of paperwork. There's a lot of transportation things. There's just issues that sometimes seem overwhelming to them. So our LCSW has been able to kind of bridge that gap because she's part of our team. She's trusted already. And so she's been able to meet with them one-on-one, provide some counseling in the interim, but then help them get settled in with some long-term therapy through a community agency in the meantime. So while there might be a 3 or 6 month gap between the time someone wants mental health care and they can actually access it, she's been able to see them during that gap. So I think if we can embed something like that in more of our programs, so in our doctor's offices, our OB offices, our schools, someone who has that time and ability to see someone right away when they're having the crisis or when they want the help, because when they want the help and when they can actually get the help sometimes is too big of a gap.
I would agree with Amy on that. We also inside of Family Vitality have a licensed clinical social worker, and Amy was out on vacation, so she might not have heard this, but we did get some approval to do a trial of a 1-year embedment for integrated care for OB for same services, because we do see, I work frequently with the OB office to try to help engage mom into need. And we find that at best, we can get them services in 6 to 8 weeks from identified need. And typically what happens is they've been struggling individually for weeks before they actually share their need to get services. So that just seems like an eternity when you finally voice the need for help to have to wait 6 to 8 weeks to get those services. And that's with pregnancy being expedited as a reason for those therapy services. I would also say that locally, what I see is a big struggle for a lot that I work with who have some criminal background, that greatly decreases their ability for housing. So they're not applicable to housing assistance because of felony backgrounds. It takes away their ability to have some offset means to make housing more affordable. So it unfortunately has them living in some conditions that are probably not the most stable for them in terms of long-term leases. So there's housing instability, and also in areas that may not be of great support to ongoing work toward their sobriety. For those, in addition to that, we have childcare. And the limit of being able to, for a mom to get a job and know that she could then have childcare in a couple of weeks when she was going to start. So we see there's long wait lists, particularly for infant care in our area, and trying to find some of those services. And then also looking at the impact from generation to generation about their legal services. So if they're not qualified, they live in a housing area where they don't qualify, maybe they have had 3 years or more where they're doing well, but they can't have that felony expunged. That felony is impacting their ability to do jobs. So more second chance employers who are willing to maybe look past some of the past, depending on how they're currently doing, versus just looking to see they have a felony or they have a misdemeanor of theft, which seems to be a big one in our area. We know a lot with substance, unfortunately, causes us to have some behaviors. So, I have some moms who at 18 years of age have petty theft. But that is always a stopper for them to work around somewhere where there's a cash register, there's funds, which greatly limits their ability to financially support their family, move themselves forward. So we just have a lot of, and I don't think that's just here locally, I think that's from a global picture, but we wonder how people cannot get out of a cycle. And it's because we put such restrictions by their past to keep them from moving themselves forward. And it makes a really hard struggle to get yourself out of.
Mhm. Thank you for sharing that, Lori. Not a lot of us, I think, work in that specific area. So to hear what you know so much from your clients' experience is interesting and heart-wrenching. I'm glad you talked about that because it makes me think about, we're talking about community conditions that affect a child's ability to thrive. And sometimes we narrow that down to what are the family conditions, and they're interlinked, right? A family needs the condition of stable housing. Well, then we need a community that supports affordable housing. So that's for me, the interlink between what kind of conditions. When I think about that baby in the first video of what is their early life experience? What are the conditions that they're growing in and therefore being influenced by? What surrounds us shapes us. And I'm sure a lot of folks on our call today or on our session today probably have some of their own insights from their work, and maybe they have some questions. So I thought I would pop some questions to everybody and see if we might be able to open it up for a discussion. I've got some questions here, and we can answer these or ask questions to folks in the chat. And I've also just sent in the chat a link to a Jamboard. A Jamboard is Google's version of a whiteboard. So if you click the link, it's like a whiteboard where you could add little sticky notes and add some of your own ideas. But I'll just take a minute for us to reflect on some of these questions and see if folks have their own responses or if they have questions for Amy and Lori. So when we think about the development of a child from prenatal through birth and early development, let's remind ourselves, what does a child need to thrive? What are the elements in our community that are providing support and meeting those needs? And where do we have gaps? We've talked a little bit about each of these. And I'm wondering if folks on the session have their own thoughts or questions about these, or maybe they want to share them in the Jamboard. So either place that feels good to you. Let's see, we'll give people a few minutes to think through. And Amy and Lori, of course, if anything else has popped up for you as you've listened to each other, and if you have other things that you want to share. If you haven't seen the Jamboard, I can screen share that as well. It looks like this. So I've got, I'm on the first page. If you go to the very top, you can see there's one of 4 pages, and you can click through for different kinds of questions. And some of the questions overlap a bit. So if you have ideas that kind of fit both, you can plop those down in the middle. But what I'm seeing here in the circle for what babies need for healthy early development, or what they need to thrive. The little bitty one says, a reliable caregiver who can meet their needs. So that's what Amy and Lori were talking so much about today. How do they support new families in meeting their needs so that they can be that reliable caregiver for their little one? Nurturing came up. Someone's added parenting classes, parenting skills. I'll pause on that one for a minute. Sometimes I use an example of building a deck. Let's say that you need to build a deck, whether it's for yourself, a neighbor, somebody you know, you need to build a deck. Do you just jump in and start doing it? Most of us don't. Most of us would either hire someone, or we would watch some YouTube videos, or we might get a book like Building a Deck for Dummies, or something like that. And so with something important like building a deck that needs a really strong foundation, a lot of us don't just jump into it. We look for resources somewhere. And yet with parenting, a lot of us just assume it's going to come naturally. But we don't live in the multi-generation homes that we used to live in, where we get to see mini versions of the generations before us parenting. So parenting classes are one way folks can get some support, but that's not really built in as a norm in our community. So I'm glad somebody put that on there. I see some paid parental leave. Yes, the Indiana Working Families. Oh, what's that title? There's something for working families in Indiana. I forgot there's another name in there, but they're working on paid leave. All right, you guys can probably see the Jamboard on your own end. So I'm going to let you jump into that through the chat or through the link in chat if you prefer to. Does anybody on have something they want to unmute and share? If you don't want to type it in, feel free to ask a question to Amy or Lori if you want to unmute or share your own experience of where you think we can strengthen the supports in our community for early development.
And Tara, I can share a story if nobody has anything.
Yeah, please do.
So in NFP, we collect a lot of data points and we share that information. And those data points are great, but they don't tell you anything at all about what we do. So a lot of times I try to tell stories instead, because that's more impactful. But sometimes it's hard to do that too, and honor someone's confidentiality. There was a book a few years ago I read called The Tipping Point, and just the gist of the book is, if you're in this world, you're doing this work, you do this work, you do this work, you do this work, you don't see any results sometimes, and it can get really frustrating. But there's eventually, when you're doing all these good things, eventually there is something that is the tipping point, and that thing might be really insignificant or seem insignificant, but it's the thing that made all the other things fall into place. And we share that with our nurses to kind of encourage them to just keep moving forward with clients, because sometimes there's eventually something that's the tipping point, and that next thing you do might be that. One of our clients early on that we had, very young client, substance use, homeless. This client was couch surfing while she was pregnant, and some of the couches she was surfing on weren't, really great environments. No car, no job, no family support. Just, it seemed like a hopeless situation for her. And her nurse just kept working with her, just one step at a time, with the next goal and the next goal. And eventually, she had a job offer, but she was going to turn it down because it required a $30 pair of shoes, and she didn't have any money at all. So we got her a $30 pair of shoes. And while that's really insignificant, a pair of shoes, that job gave her so much confidence, and everything just started falling into place. All the things she learned, all the things that she hoped for, she could see some light at the end of the tunnel and some options. Before that job, it really looked like she might not even be able to parent this child. It could be a open DCS case whenever the child was born. But before this child was born, this parent was able to save up enough money, get into some low-income housing, buy a really inexpensive car, and provide a home for her child and parent her child very well. And so it's just motivation, I think. So if you're on this call, then you probably do some work in this area. And sometimes it can be daunting, and sometimes it can feel like you're not making any progress. And sometimes you get to be the person that's the tipping point for somebody. So just keep moving forward and keep working toward everything.
Thank you, Amy. We need those words of encouragement, and we have talked about how important mental health is for those who work in this field, and being able to see tough things and to keep showing up the next day to support those who need it. While we're on that topic, can you talk a little bit about how that's baked into the nurse family partnership model? not because we think everybody's going to be able to create a nurse-family partnership version in their own space, although we have one here in Monroe County and several surrounding counties, but maybe we can learn a little bit about what supports you guys have built into your staffing that others might consider building into theirs.
Right, so it's relationship-based care. So it's really important that the staff and nurse-family partnership are committed to this work. And we're so fortunate to have an awesome staff that's very committed. But to stay committed, you've got to take care of your own health. And if you have 25 to 30 clients and, a lot of, things that are hard to go home and not take home with you. We have a client that you just showed up at their doorstep and they were just beat up by somebody. That's not something you can leave that house and not be upset about or not think about later. And so we embed a lot of just regular meetings to kind of decompress and talk through how we feel about things. So each NFP home visitor meets with me once a week in a one-on-one visit where we can talk about their cases and just talk about what struggles they might be having. We have a once a week team meeting where they can share with each other. And then each of them kind of has partnered up with someone else on the team that they can just quickly debrief with. And we have a group texting chat that, if someone has something really big happen and they need to talk to someone right away, they can text in the group and someone can call them and talk with them if I'm not available. So that team support and one-on-one support is embedded every single week, whether we think we need it or not, because if we don't need it, we will need it. And that model, I think, is something that I wish was embedded in a lot of workplaces.
And I don't have such a team. It's just myself and one other who works, but her work is around fetal and infant mortality review. So we do use each other as a support services. I have also embedded myself inside of NFP, so I attend their meetings, so I'm able to kind of share and hash out feelings. But also inside of IU Health, if something very traumatic has happened, we do have employee assistance. So we are all eligible to go and we can kind of work through those with trained mental health professionals. So that's another level of support that's not necessarily embedded in each system, but as an employer that is embedded there.
You've each used the word embedded, and for me that means it's built into the structure. Like if you know that the goal is for these staff members to support the family so they can support the early development of their infants, you know that you need stable staff members. And what does it take to have stable staff members? You need to have supported staff members. So you build that into the structure of their role. And I think it's so easy for many of us to think, oh, we want to do this, but then we miss the parts that need to be built in order to make that thing an actuality or to make it effective. And when we talk about, oh, we need family engagement, well, what things need to be built in along the way to actually make that come to fruition. And so that makes me want to think more about that. Where can we make adjustments or add greater supports that make this work actually able to happen because the staff can do what they're hoping to do. So I've got a lot to think about there. I'm going to move over to the Jamboard again, just to see some other ideas that have been popping in there. Some folks have added a few things to thinking about what's needed for early development. What would be a part of a community? Affordable housing has been added in. A go-to place, a resource center for parents, a crisis nursery. Okay, it looks like we've mapped out some of those things. If you haven't given consideration to that, I think it could be interesting to think, where are we rich in the community? I think Lori gave us some examples of family planning and birth control and some places there where we needed to think about the systems that could be better supported to new families. Gaps, what are we missing? Where do we have room for growth? Where are our chances for collaboration? And then as I think about the topics that have come to mind for me today, what I always want to do is let those thoughts settle and think about them, stew around a little bit. But then eventually I want to get to this question: what actions do you hope to take or encourage others to take to support early development in children? You know, there are actions that we can do at the individual level about recognizing families, making eye contact with a new family, speaking gently to a little one that might be passing through our space. What can we do at the individual level and in our relationships that prioritize early development? What can we be building into our organizations, into the structures in our community, into the policies that can support early development? If we know that early development is so important for their own growth and for their brain development and the structures and for the relationships that they're starting to have, that then carries on to them through preschool, into school, and into adulthood, what can we be doing in those early years to support that? Those are the things that I'm hoping that many of us are thinking about. So if others of you have ideas that have come to mind for you, we'd love to hear what's working for you, where you've been seeing success, where you think there's some traction to have greater support in this area. So please feel free to keep using the Jamboard. I'll be checking back at that to see if others have added things in. And we have a few minutes left here if others have ideas that they want to hop on and share. I see lots of familiar names of people who have been working with families or who have supported children at various stages of their development and might have insight of where they think we can learn from their work. So I'll give you a minute to think about that. I'm going to keep looking at the Jamboard a little bit too to see what other ideas are popping in. Amy and Lori, as folks are thinking, are there any other insights? I know you've got, you know, some 2-3 decades worth of caring.
I actually had a question.
Oh, good, Nick, thank you.
So I know that Amy, you talked about how you did the ACE screening with every pregnant person, and that brought up 2 questions for me. One is, you know, just what's that process like with asking people about those ACEs, and then, you know, how does that inform your work, and how does that affect your relationship with people? And then the other part was, when you were using the phrase pregnant person, I'm assuming you're doing that to include people, you know, across a variety of gender identities who can be pregnant. And I was wondering what it's like to work with people who maybe have a different gender identity than cis females.
Yeah, so great questions. I actually uploaded, there's a place on the app where you can upload articles, and I uploaded a thing. It looks like this. My video won't come back on, so hopefully you can see me. I'm not sure, but it says what are ACEs, and we actually use this to kind of talk with our clients about it, and we talk to them not really about their trauma as much as we talk about resiliency and how we can help them build resiliency. And the bottom of the page, it says, no one who's experienced significant adversity or many ACEs is irreparably damaged. And that's kind of the message we want to make sure that they understand, that their past doesn't necessarily dictate their future, but those are things that we still have to take into consideration and work through. So I'd encourage you to take a look at that education page. It's from the Center for Developing Child, Harvard University put it out, but it's really got some nice graphics and good information. And you're right, I do try to use the word pregnant persons, and it's really hard sometimes though, because it's, you know, it's so used to saying the mom or the women, but we do have, you know, clients who identify as different genders, and, you know, we're just honest with them when we talk with them. Like, we want to respect their wishes, and you know, if they want to be called dad, or if they want whatever they want to be called. But it's sometimes, you know, when you're talking about very female centric things, you know, chest feeding rather than breastfeeding, things like that, it's really easy sometimes to say the wrong thing. And so, you know, we work hard to build trust with our clients, so they're usually very forgiving of us if we do mess up and not use the right pronoun or something like that. But it is something that we do see a fair amount of that here.
I think the one thing I always tell my clients is please feel free to correct me. I will never use the wrong pronoun intentionally. And I will never be offended when you correct me because I want to do, I mean, I want to support them in that, but it is unfortunate. Sometimes you do just get lost in it being a female health and having the wrong pronoun to use just is kind of easy sometimes. And so I always tell them to please feel free to correct. I also tell them that when I'm doing their intake because I talk to them about what substances they use, how frequent, and it's my approach is this is something that people do every single day and there's nothing to have judgment or shame about. But if I ask something that it makes them uncomfortable or something that they feel I phrased in a way that was offensive, to tell me that and we can talk through that, because without that, we're not going to have the trust that we need to move forward. So we are all humans. We will all say the wrong thing unintentionally. And maybe what we say is correct, but it's heard in a different manner or it's felt differently. And I think it just gives them free space to know that that's an open and safe space to share their concerns back and forth.
Yeah, thanks for highlighting that, Nick. I'm glad you caught that language and highlighted that for the rest of us. It's good to learn and grow from each other. You know, some of us are experts in very particular fields, and yet all of us learn from each other. So I hope that you guys can connect to somebody else on this call. Those of us who've joined this session in some way or another care about early development. We care about the health of new families. So please take a glance at the other folks who are on this session and see if there are places where you can collaborate or where you can support each other's work or brainstorm together. The Whova platform will be available for us. The Jamboard link is there if you want to copy that, if you haven't already, if you want to continue to share ideas there. Amy mentioned posting something in the Whova platform, and that will be available where others can post their resources or share their ideas. But I appreciate that Amy pointed that out, because that can be just kind of a housing space, a little archive for us. So today we started thinking about the early years. I started with a video of a baby, thinking about the early development and the supports that the family and the community can give to help in that early development. And you're going to go on to some other sessions this morning that will talk about childhood and all kinds of time spans and different conditions that affect childhood. But I want to thank Amy and Lori for getting us started this morning, for sharing their insights into the unique work that you guys do with new families. To do a home visitation program is pretty unique, and to do it with the clients that you do and see the dynamic things that influence a family are really interesting for those of us who don't do that on a daily basis. So I appreciate you sharing what we don't see through your lens and your insight. For the rest of us, we are moving on to our other sessions in just a little while. You can go back to the Whova platform, and that will house the agenda. So the same way you got into this session, you can click a link into the next session. If you've decided that you would like to join in for the afternoon and you've not had a chance yet to register for that, you can still do that. You can still go into Whova and add yourself for the afternoon. We're going to be in person at the library. And if you decide to, you just want to walk in and join us that way too, that's also an option. So we hope that you'll continue to think about childhood conditions, whether you stay with us today or whether you go through your work. And I hope you'll continue to share with each other. So thank you, Amy and Lori. Thank you, Nick, for hosting us in your Zoom room. And thanks to everybody who is joining us today. I hope to see you at a session here in a little while. Goodbye, everyone.
Bye. Thank you.